Yeah.
Okay, sounds good. So thank you for all to come here today and to share my presentation with you all. So I'm coming here today to talk about a case of multifactorial atrial tachycardia as a typical presentation of cardiac myeloid sarcoma. So we had a patient, a 52-year-old male, that was admitted to the emergency department of our hospital due to palpitations. He was on the third day following a new chemotherapy scheme with venetoclax and Vidasa. His past medical history, which is very important right here, it's that he had primary essential thrombocytosis, which was diagnosed in 2010, which progressed to myelofibrosis and acute myeloid leukemia. The patient was treated with various chemotherapy schemes and received an allogeneic bone marrow transplant in 2020, complicated by acute graft versus host disease. Talking about his acute graft versus host disease, he had predominantly skin presentation and liver dysfunction. So in the emergency department, his physical examination showed a bilateral flank abdominal mass and tachycardia. His EKG shows multifocal atrial tachycardia. His laboratory investigation demonstrated a severe neutropenia and thrombocytopenia. And he performed a transthoracic echocardiogram that showed a right atrial mass. Initially, he was treated with amiodarone and admitted to cardiac intensive care unit. In the cardiac care unit, when me and Dr. Giuliani received the patient, we asked for a cardiac magnetic MRI, which revealed an infiltration mass in both atrial walls, more in the right atrial, which had isosignal intensity in T1 and high intensity in T2, and weak enhancement by contrast, suggesting a tumor mass. And then after a lot of discussion, we thought about granulocytic sarcoma. So granulocytic sarcoma, also called myeloid sarcoma or chloroma, is an extramedullary tumor of immature granulocytic cells. It is a rare entity and most accompanied by acute myeloid leukemia, which was the case. A first mention of the pathology was found in 1811 by Burns, and later called chloroma on account of its typical green appearance caused by the presence of enzyme myeloperoxidase, MPO, in the granules of the immature granulocytic precursor. It may develop concurrently with mentioned primary disease or be the initial manifestation of the relapse in an already treated case, especially after allogenic bone marrow transplantation, which was our case. So in the literature, according to the article published by Meyer in 2019 on the Radiology and Oncology journal, the commonly affected body regions were visceral soft tissue, followed by cutis, and it can be swelling or changing coloration of the cutis, bones, and central nerve system. The cardiac presentation in this article was 2.3% of cases, 2 cases. And in addition, both cardiac cases was identified incidentally by imaging. So what usually we see on literature is that cardiac manifestation usually is incidentally. So we got a very rare case, which the cardiac manifestation was the multi-atrial tachycardia. So clinically, myeloid sarcoma was apparent in half of the cases with swelling and skin discoloration, as I said before, which underlined the importance of a good physical examination in oncologic patients. Furthermore, in 29.2 neurological and organ dysfunction were found, and 21.5% pain was the main symptom. Notably, 11.3% of MS cases was detected incidentally by imaging study. Eventually, due to increasing performance of imaging study in oncologic patients, we hypothesized that the amount of the incidentally detected MS will increase. Therefore, the radiologists, oncologists, and cardiologists need to be aware of the intensity of MS. There were another reveal by Lam K, which he followed up 12,000 patients in 20 years. He found in their autopsy that the cardiac involvement by leukemia was 40%. And the majority of this remain undiagnosed in living individuals. Furthermore, the most common symptomatic was pericarditis. So again, our case was very rare in literature. So to conclude, our case, which was a cardiac arrhythmia, multifocal atrial tachycardia, was the first clinical manifestation of this patient. And GS was presumptive due to cardiac intracavitary mass found on the echo on the ED. Also, after we asked for MRI, which has the same presentation of GS tumor. Moreover, after cardioversion, the sinus rhythm that the patient was, the PR interval of the patient before the cardioversion was 380 due to the cardiac conduction infiltration that we saw in the MRI, explaining the first-degree heart block that this patient had. So, and after all of that, if you remember, in the physical examination, we saw right here that the patient, he had bilateral flank abdominal mass. This mass was biopsy. We sent this to biopsy, and we got the conclusion of granulocytic sarcoma. Anyway, so due to its rare incidence and the lacking of data in our literature, we are here exposing this case. So the main purpose of this report is really to highlight the different forms of cardiac presentation of GS and to contribute to medical literature as GS remain a clinical challenge. Thank you.